Okay, it's almost 12:03 by my clock, and so I think it's about time that we get started, and hopefully some other people will join in as we go. My name is Harry Hockheiser, the director of the Models of Infectious Disease Agent Study, or MIDAS Coordinating Center. So welcome to our monthly MIDAS webinar for February 2022. I'm really very pleased today to have as our guest speaker, Ifeoma Ozodiegwu. Ifeoma is a research assistant professor with the Malaria Modeling Research Group at Northwestern. Ifeoma was trained as a doctoral training in applied epidemiology. She's got a couple of years of postdoctoral training in applied mathematical modeling. Her research focuses on the development of quantitative frameworks for understanding malaria risk and interventions in endemic countries. And she's also PI on a grant to develop the first mathematical model of malaria transmission for urban areas in Africa, which is a very real problem. She's also been honored with a Rotary International Global Grant and has done a bunch of other interesting things. She's got a nice little personal website, which has got some interesting papers in progress I would encourage people to check out as well. So Ifeoma, we're really pleased to have you here. Thanks for agreeing to speak with us, and I will leave the floor to you.
Many thanks to you, Harry, and thank you for the opportunity to present. Many thanks to MIDAS. So my talk today is really to describe how we developed a mathematical model to inform malaria policy decisions in Nigeria. As part of this talk, I hope to also describe how we made this model accessible and also provide some thoughts on how we can sustain modeling informed decision making in Nigeria. So to give you the context, why Nigeria, because you probably may have this question if you're not in the field of malaria. Nigeria actually has the global share, greatest global share of malaria in a globe, has the greatest global share of the global malaria burden, basically. And this pie chart that I show on the left of the screen actually shows malaria deaths in 32 high burden countries. And what you see is that Nigeria actually has 23% of the global burden of 23% of the global malaria deaths out of all the 95% of deaths that have occurred. So that's a huge burden of malaria in the country as compared to other high burden countries. And when you look to the right of the screen, sorry, I think I'm having issues with my, okay. So when you look to the right of the screen, you also see the burden of malaria cases in Nigeria. Hold on, I think I'm having issues with this. Okay, so it's what the second pie chart is showing is the global malaria cases that have occurred in 29 high burden countries, and Nigeria bears about 27% of those. And so when you compare to other high burden countries, Nigeria still has the greatest global share of malaria cases. So another information that I think is important to provide context as to why this work was important is also the fact that over the past 10 years, while we have seen progress in reductions in malaria deaths and cases, we have also began to see some stagnation or slowing in this progress. So this plot here is malaria deaths in Nigeria over the past 20 years, since 2000. And this is malaria deaths per 100,000 population at risk. And you'll see that in the last, between 2000 and 2010, there was a very sharp decline, and even up until 2015. But in the last 4 or 5 years, we begin to see the slowing of the malaria deaths. And this here, yellow dots, represents the global technical strategy targets that was developed or initiated by the World Health Organization. And the goal is to decrease malaria deaths and by 40% relative to the 2015 estimate. And while Nigeria, as of 2019, might nearly meet this target, what we are estimating is that the likelihood of us achieving this target, of the country achieving this target, given the slowing of malaria deaths, is unlikely. And we also see even more so for malaria incidents. So you see here, again, a very similar plot, but this is malaria cases per 1,000 population at risk. And you see that the gap between the incidence that was recorded in 2019 and the global technical strategy targets, again, is even more distant. And so the likelihood of achieving this target is also pretty low. So what would explain some of this slow progress? For people that are not in the field of malaria, there are various factors. So there may be, in some context, environmental issues around climate change, shifts in urban-rural migration. So this is also perhaps causing an increase in urban agriculture, which creates habitats for promote vector breeding. There's also issues around socioeconomic factors, again, using the example of urbanization, people moving into slums, people moving into shanty houses, and these houses increase exposure or increase your likelihood of exposure to malaria vectors. And there's also the sorts of jobs that people are doing. So maybe because of economic factors, people are also doing more seasonal work, and on seasonal agricultural work in this case, which also increases their exposure. And secondly, there may also be issues of interventions. So the accessibility of interventions, the history of interventions, the timing of interventions itself, which may be affected by various factors, including funding and things like the lack of political will, the lack of infrastructure, the lack of capacity. And there also are issues that relate to parasite and mosquito-related factors. So the parasites, we're beginning to see more drug resistance, especially in Asia. But we're also seeing, mosquito-related insecticide resistance. And so these types of factors may explain the progress that we are seeing globally, and to some extent may also explain the progress that we are seeing in Nigeria. But what I think is important to highlight, however, is that the factors that may explain the transmission dynamics in the country will differ according to different geographic areas, because malaria is really heterogeneous at fine scales. And so what I'm showing here is a map of Nigeria's 36 states. And the capital, which is located here. And so I tried to color this map to sort of highlight the point that malaria is heterogeneous at the state level and also heterogeneous at the district level. So Nigeria has 774 districts. And so what this tells us is that if we want to achieve targets, the global targets, I've given you, I've spoken about the global technical strategy targets of reducing malaria burden by 40% in 2020, but there's also additional targets for 2025 and 2030. And this is, the target in 2025 is to reduce burden by 75% with respect to the 2015 estimate. And given all this information about the heterogeneity of malaria and differences or spatial variation in transmission, what we would expect is that if we want to meet the targets, we really have to tailor these interventions to the local context. And these ideas, I think, ideas that come from or underpin the high burden to high impact initiative that was launched by the WHO. And the goal really is to support national malaria programs to optimize their investments in malaria and to achieve greater reductions in malaria burden. And so what that looks like is a combination of actions based off of 4 elements. The first one being political will, strategic information is the second one, better guidance and coordinated response. And the goal that the global stakeholders are trying to accomplish is to reduce morbidity and mortality for malaria. And the one that I think the element that really concerns our work is the strategic information, where WHO wants countries to really move away from a one-size-fits-all approach to intervention planning to a much more targeted approach to intervention planning. And that would result in an outcome that's of having evidence-informed national malaria strategic plans. And so that is really the task that the program, as well as it combined in collaboration with the WHO, gave my group to do. So they have the main question they are trying to answer is, what is the most appropriate intervention mix for each of those 774 districts that can be used to inform the National Malaria Strategic Plan for 2021 and 2020. So this was work that was conducted during my postdoc, which was between 2019 and 2021. So prior to when, I think another point that I think is important to make before we talk about the model itself is that the WHO also has a process for intervention stratification that would really that really feeds into the modeling aspect of developing National Malaria Strategic Plan. So I will explain. And so what that looks like is that in countries, or what WHO recommends for countries to do, is that for each of the operational units, in this case, the districts in Nigeria, there would be a set of recommended interventions that the WHO would each country would have to consider. So there are recommendations and clear targeting criteria for vector control, chemo prevention and treatment. And then there's also the information for each of these districts. So epidemiological information like prevalence, seasonality of interventions that they would also need to use to stratify these areas by areas of high risk, low risk, and then they can use the information they have on the different targeting criteria to decide where interventions should go. So once the countries have done this, then they can start to model the different intervention scenarios. And that's where my group would come in, is to present, develop a model that would help these countries make decisions as to what intervention will be most appropriate. And then the country can then use this information to start to set targets and goals for their strategic plan. So that's really what the process looks like from the country level, and how, and also in terms of how they interface with my group. So a little bit more information is that when it comes to the recommendations on intervention targeting, something I need to understand is that there are different criteria. So for bednet, which is the key vector control intervention that is used in Nigeria, what the WHO recommends is that there's universal coverage of bednet. So that is why here is all green. But in urban areas where there is more heterogeneity in transmission, bednets are typically given in areas where there is higher transmission, so places like slum areas. Other series of interventions that the WHO also has in mind or would typically recommend for places like Nigeria would be seasonal malaria chemo prevention, because in the northern part of the country, there is more seasonal transmission, and this is typically given to children who are between the ages of 3 to 59 months, so basically children under the age of 5. And in areas where the transmission is not seasonal, interventions are given to kids who usually show up at EPI, and so that is the recommendation for reducing burden in those areas. There's also the community health worker program, which is incorporated into the integrated community case management of infections. And so what this would involve is that for various illnesses where in various areas where health facilities are not easily accessible, the community health worker can diagnose and treat a variety of illnesses, including malaria. So that is, the different recommendations that the WHO has for different malaria interventions and where they would go in Nigeria. So Nigeria, as the program in this case, took those intervention recommendations and came up with a plan. So this was an ambitious national plan that they came up with for the different intervention mixes where they would go in the country. But basically, to simplify this, you'd see that almost all areas get both CM, which is case management, almost all areas get chemo prevention. So the main thing I think here is that what made this really ambitious is that they wanted to move away from using a standard type of net to a much more advanced type of net, which is called PBO. The standard type of net, most areas are, mosquitoes had already developed resistance to those types of nets. So they wanted to try this new type of net to which there's less resistance to, or very little documented resistance to those types of nets. But however, when the program also began to consider cost considerations, they needed to cut down the ambitious plan. And so they came up with a second series of plans. And you have to remember that all these plans are plans that are going to be given at the district level. So they had these plans, but this time around, because of cost considerations, they decided to give the standard type of net in more areas. So that's why you see a bigger yellow, bigger pink here. And these standard types of nets were also given together with seasonal malaria chemo prevention, which is given for children under the age of 5. And then they also tried out a new type of net, which hasn't been tried out in Nigeria before. So this was what they could afford. And so the goal for us as a modeling group was to take those plans that I've just described, the different intervention mixes, and try to model them and try to help the program understand what would be the impact of these plans with respect to burden metrics, and for each of these districts, and to do that for the period for which they plan to have the National Malaria Strategic Plan. So, and in presenting the results, they wanted us to also aggregate these results and present it at the state and national level. So I'm going to talk about how we approach developing the model. So our model, we developed it is in EMOD. So EMOD is an agent-based simulation model of malaria transmission. And what that entails is that, first of all, we have a vector component. So it's a model of a climate-dependent vector life cycle. And then there is also a model of human disease and human immunity. And these two models are coupled together. And also the model includes intervention effects. So it's a very complex model of malaria transmission. So when we took this model, which had already been developed, because it was developed by EMOD, but it hadn't been tailored to the Nigerian context. And I would also want to mention that there were other, however, some characteristics or aspects of the model had already been calibrated to field data. So things like parasite dynamics had already been calibrated to field data before we used the model. And so in our model development framework, we viewed it as a series of periods. So there was a baseline period, and we call this period a baseline period because when we looked at the history of interventions in Nigeria, most interventions had not been carried out. I think there were just few areas that had received bednets. And so we call this period the baseline period because this, given the few interventions that had been carried out, most areas would be able to capture the potential, the intrinsic potential of each of these areas to support malaria transmission, basically. And so once we can capture the potential of each district to support transmission, then we can start to understand the effects of intervention. So we can layer the intervention on these areas, and then we can also validate our model, and then we can go ahead and start to make projections. So a couple of things in order for us to make sure that the model captures transmission dynamics in the Nigeria setting is that we needed to calibrate the data to seasonality from routine case reports. So routine case reports in Nigeria are typically data that are collected from health facilities. These are public health facilities, and so they are usually recorded on paper and then uploaded to a data management platform. So the program allowed us access to this data. We are only able to capture seasonality from this data because most people don't really receive care from public health facilities. A lot of people receive care from private facilities. And as a result, it would give us a sense of what the seasonality of malaria is, but it would not tell us what the transmission intensity is. So in order to understand transmission intensity, we decided to use the national prevalence surveys. And these national prevalence surveys are typically representative at the state level, but not at the district level. And then the other thing that we needed to capture, if you remember, there is the intervention period within the model, is the intervention effects, and we try to capture this by using effect sizes from the literature, as well as coverage data, so that we got from very similar, the same national prevalence surveys as we capture transmission intensity. We also have the distribution schedule that we obtained from the program. So that gave us a sense of the history of interventions. So now let's talk about how we overcame the issues of data poverty or paucity, because that is also a key thing that we had to deal with while we were trying to calibrate the model. So here you see a map of malaria prevalence among children under the age of 5 from one of the national surveys. So when we map this onto a district map, there are several areas, several districts for which we did not have any data. And so what we decided to do is to try to cluster districts with similar seasonality and transmission intensity together, and then parameterize them accordingly. So in order to group these districts, we use information that we know is related to seasonality and transmission intensity. So information like monthly rainfall, temperature suitability index, the relative abundance of the tree vector species, and we remember, if you remember, I spoke about the calibration being done in the pre-2010 period in order to capture the intrinsic potential of the districts to have malaria transmission. And so what we use the pre-2010 malaria prevalence here because this was the period of calibration for seasonality and transmission intensity. And so we also use bednet coverage. That, I think for us, we found that seemed to be the only intervention that was implemented within the period of calibration. And so by the time we completed the clustering, we used a hierarchical clustering framework. We end up with 2 epidemiological archetypes. And so that makes it easy to calibrate, because even if we had the data for the 774 districts, that's a lot of areas to calibrate to. Or calibrate the model to. So it also reduced the computational burden for and made our work more tractable and easier to complete. So this is an example of how the plots that we generate after we calibrate the model to routine data for seasonality. So we try to capture within routine data the shape of transmission. So here you have on the y-axis the malaria cases, and so this in blue is the routine data, and the red is the simulation. And so this here is a calibration we did for a particular archetype. What this implies is that for every district that fell into that archetype, they have the same seasonality. And the second thing that we captured is the transmission intensity, which we calibrate to the malaria indicator survey per archetype in the same manner. So what you see is the prevalence in children, malaria prevalence in children under the age of 5 from one of the national prevalence surveys. We generate estimates on a monthly scale to capture the transmission intensity. So the second portion of our model parameterization is capturing in intervention effects. And to illustrate again the problems that we face with data paucity, here is a map of treatment seeking rate for symptomatic malaria across 4 years. What you see in the circles are clusters that were sampled as part of the survey. And when the clusters are sampled within an administrative unit, we compute a weighted estimate that is then applied to represent the estimate for that district. So the spaces you see, or the blanks, or the gray areas, are areas with no data. And we see that over time, particularly in 2010 and 2015, we had many areas with no data. And so to overcome this, we also use the same archetypal framework to generate an estimate for those areas that had no data. And that way we could have maps or we could generate maps where every area had some sort of estimate. So with respect to intervention effects, here is an example of how we approached estimating the bednet killing rate. So within the model, one of the estimates that is important for us to capture is the rate at which the bednets kill mosquitoes. And so what we look at to do, how we approached it was we went into the literature and we identified papers that had studied the relationship between predicted mosquito mortality in a bioassay. And so this is a measure of insecticide resistance. And we looked at, and we were able to estimate the relationship with the killing rate. And the Malaria Atlas project had already produced a predicted surface of the mosquito mortality. In this case, against permethrin is a pyrethroid, so it's a type of insecticide. So this map represents insecticide resistance across Nigeria. So, and this is also a predicted surface. But since we already know the relationship between the resistance and bednet killing rate, we can then use the information from this map to then generate a district level map of bednet killing rates. So this is what it looks like. So with respect to the intervention history, we only had this data at the state level. So we had to make the assumption that if an intervention for, in this case, bednet distribution was conducted in a state, then it was also conducted within the districts within that state. So that was, approximate or assumption with regards to malaria intervention history. So I've described how we approached calibration of the model, including parameters within the model. The next portion is to talk about how did our model perform after we made all these assumptions and we used the data that we had existing. And so what we found is that when we started compared the model prevalence and the data from survey, so we calibrated the model in 2010 and then projected it outward to 2019, but this is the years, what you see here, the years for which the survey had data. So we had survey data for 2015, we had survey data for 2018. And so we wanted to see, would our model predictions match what we see in 2015? And you see that it doesn't do so well. But again, our model is also based off of a lot of poor quality data. And so even though our model didn't do so well here, we can still use this model to compare the relative impacts of interventions. And I will describe that shortly. But a second validation that we did was also to look at incidence, because we wanted to see, would our model also capture the shape of incidence as at 2018, for which we had data for? And you see it doesn't do so well either. But again, the data is also quite poor, because this is, in the purple is the confidence intervals for the data, and it's quite wide. So again, how much trust can we place on the data itself? So that is kind of what we concluded, is that we can still compare our intervention scenarios because we can look at the relative impact of interventions against each other, even though our model is not doing as well, because we already know what we should expect given the two intervention plans that I've described, the national plan and the fundable plan. So that's what I'm going to show you next. So the projections from the model is what I'm going to show. And so you see here in the black line, this is the historical projections, and the red line is the future projections. And so the future projection, we started by looking at a scenario of business as usual. So what if we were to have interventions at the same coverage level, at the same intervention mix as in the past? How will that compare, and how will that perform when compared to a much more sophisticated set of interventions that are at a higher coverage level, which is what this national plan represents? And our model, actually, the predictions matched our the model results matched our expectations. So we see also that the national plan performs way better than less sophisticated intervention mix that was at lower coverages. So we see that same situation both for incidence and both for mortality. And what this model projection seems to suggest is that the incidence, so we have these targets that are previously described, the global technical strategy targets that the World Health Organization had set. And so these were the targets that Nigeria had hoped to meet. And so with this sort of illustration, it became easy for the program to see that even with the national plan, there is also a high likelihood that these targets might not be met. But the chances of us achieving these targets are much better than if we went with a business as usual scenario. So what this model provided us was a framework for testing our assumptions about interventions for malaria. So the other plan that the program had wanted to look at was the fundable plan. So this was a plan that the program had developed after cutting the national plan due to cost. So I think with this illustration, they were able to see the implication of the fundable plan. So how does that plan compare to the national plan? And then that could also give the program the resources and the tools to advocate for more resources in the future. So the next thing I'm going to talk about is, of course, is the limitations of our model structure. It's pretty obvious that our model is based on poor quality data, but I centered the discussion on the limitations on the model structure because that wasn't really made clear. And the key thing I think to highlight is that we assume, we made a couple of assumptions that might not hold. One of them being the fact that we assume there's no mixing between districts and there is a uniform importation rate. It's likely that it could hold in some low transmission districts, but not necessarily in high transmission districts. We build our model without accounting for long-term trends that could also be responsible or could also be associated with reductions in malaria risk. And we also, our model predictions for malaria deaths in particular do depend on treatment and mortality rates that are also based on very limited data. So we've talked about the model, we've talked about the limitations, and we've talked about what the models were able to do for the program. So now I want to talk about how we made all this information accessible to the program. So in order to make, because we did presentations with the program, we shared the results as slides, but we also wanted to make sure that the program was aware of the limitations of the model, what we calibrated the model to, what parameters we use. This was important for us, to be as transparent as possible. And so we developed a Shiny app. This is the interface that I'm showing you here. So when you get into the Shiny app, you can actually see for each intervention scenario, by clicking on these drop-down buttons, you can select the year, the coverages of interventions that were used. So all these parameters were made available within a Shiny app that the program could access and also download and validate. The app also included the projections. So the projections for at the national level, at the state level, at the district level, were made available in a format that the program could access and share with key stakeholders. And for individual states, if they wanted to access this app, they could easily just go online and access it and use the information to advocate for resources if they wanted. By illustrating this illustration, for instance, it shows for one of the states where they are with respect to targets. And we had this information for the all age group and also for the under 5 group as well. So the next thing I'm going to discuss is what my thoughts and our reflections on what I think can help sustain modeling evidence. Because as you can see, even though the data that we used was not the best and we had a lot of challenges in developing this model, it also still was a good decision-making tool for the program because they could they had a framework to use data and the best available evidence to inform their decision making. So how can we sustain that moving forward? Because this was the first time that this had ever been done as part of setting targets. And our reflections for doing that, I think, were quite so many. And I'm going to highlight a couple of them. And I think one of them is that I think from my perspective as a modeler and someone that is continually trying to develop models to work with national programs, I think it's very important that we are as transparent as possible so that the program can actually question the model and be active participants in the development of the model. We also want to make sure that they are, since they are stakeholders in the process, that they are carried along. And so in data gathering as well, it's imperative that they own the process of the data gathering. They are part of the analysis, because this is their data. And if they do not own the process, then it will be very challenging to convince folks in the program to use the model predictions to inform their work. But I think for me, the key takeaway, however, is that we need to sustain model use by embedding capacity for local modeling within malaria endemic countries. Because it's very weird to, if that's the right word to use, to be doing National Malaria Strategic Planning or informing National Malaria Strategic Planning from an international institution. This is akin to having the US, for instance, have someone from South Sudan develop a model to inform COVID modeling. And from my perspective, these are some of the things that create disparities in health and in socioeconomic development in malaria endemic countries. And so I think from my perspective as a modeler, to sustain model use, to also sustain quantitatively informed decision-making, it's imperative to build the capacity within the program, within universities, in order to sustain the use and application of models. So I'd like to thank several people that contributed to this work, because this is not just my project, but the project of several organizations and individuals. Key among them is the National Malaria Elimination Program, led by Dr. Perpetua, who has been very gracious to give us this data and support us in this work. And more importantly, the World Health Organization, who trusted us to conduct this project. And then finally, my mentor, Dr. Jalene Gerardine, who continues to support me even as I have transitioned from my postdoctoral work, and who sort of provided me with the guidance that I needed throughout my postdoctoral training in order to expand my thinking as to how models can be used to actually inform public health decisions. So thank you all for listening, and I look forward to your questions.
Great, thank you. Very interesting talk. I'm seeing something popping up in the questions and answer already from Kat Shea. Can you use results of impacts of known interventions in similar districts as experimental results to improve your model in a sort of adaptive management approach?
Certainly, if we have that data, we would. In this case, we just didn't. So it's very challenging when you don't have data. You just have to, make assumptions here and there, and that's what we try to do.
Great. Well, I've got a question here that sort of follows on. I mean, first, I think I really love, I like your emphasis on bringing this to the decision makers and how you communicate that information. Did you consider doing anything like a sensitivity analysis among the different interventions or different mixes of interventions to begin to see, what would get at different levels of differences between the ideal and the fundable, and how specific decisions about what to do where might change the overall mix? I realize there's a lot of complexity that could come in there, but it seems like that's what decision makers might want to get at. Yes,
that would be wonderful if that was also like this was an academic project. For the decision makers, they had two scenarios, and they had different coverages. So what I displayed to you is just a few of the different scenarios we ran. We actually ran 7. But for two of the scenarios, these were very similar to the national plan that I described, but at different coverage levels. And the rest, the three of those scenarios were for also different coverage levels for the fundable plan. So we did try to look at different intervention mixes, or no, different coverages, not necessarily intervention mixes, because that was what they wanted. Because this is also a project that is in response to an ask and not in response to, what we wanted to do. So we just had to abide by what they wanted from us and the sorts of analysis they wanted us to carry out. Does that answer your question?
Yeah, great, thank you. I mean, I think, clearly not a criticism of sort of what you chose to do, but I guess I'm just thinking about this from what could help policymakers in some ideal sense would be if they could do a little bit of the sort of, well, what if we did a little bit more of this intervention here and a little bit less over there, and we change our mix of our limited dollars in different ways to see what we think is likely to happen as we do that, could allow them to explore a broader space of possibilities than they might have thought of initially. Because you've got this question of what to apply where and when, which makes it a fairly complex set of things to optimize, and providing more tools to ask questions that are hypothetical, there might be a way to support that decision making.
Yeah, I think we get close to that because we do run several scenarios. I only present a couple. But again, we also had to trim those scenarios in accordance to what they asked of us. So, sure. And I think the decisions that were made with respect to where things should go are really decisions that should be made by the policymakers and not by us. This is also a very highly sensitive and political project, so we just couldn't do that as well.
I have no doubt. All right, another question here that came in from Lauren Cohey. Have you Have you modeled other alternative interventions, e.g. malaria vaccine or increasing the age of SMC to include school-age children?
Yeah, so this is not work that is being done by me at the moment. We have other members of our team that are already doing this. So yes, that is work that is ongoing, but not being hasn't been published yet.
Mm-hmm. Great. Any other questions? Folks can speak up or unmute. I will unmute you if you want, or jump in. I'll throw out another question that came to mind here that I'm sort of curious about is the possibility of, when I looked at some of those numbers that you had about the goals versus the possibilities of what you'd get with these various intervention plans, those struck me, just based numerically looking at it, those struck me as being very ambitious goals. Because it seemed that if I was reading it right, I thought I saw something like a 90% reduction in cases, that's substantial, right? And so, yeah, there you go, exactly. So it's about, if you look at the malaria mortality, they were looking at that essentially a 90% reduction, right? So is it reasonable to use a model like this to sort of begin to say, well, when is a goal not realistic? And of course, given the political sensitivity, I'm sure that was not something you would have gone anywhere near actually saying that, but just thinking about what the model might be useful for or not. And I just would love to hear your thoughts on that.
Well, I think when the WHO sets goals, they are well aware that these are really ambitious goals. And I think the goal typically is set with the aim of getting countries as close as possible to those goals. Yeah. So it's not necessarily, I think the ideal situation would be to get to malaria elimination. And that is why those goals are being set, because we want to end malaria within endemic countries. But what can this model help us to assess the realism of these models, of these scenarios, or the realism of these targets? I think for me, from my point of view, the value of this is really to help countries really see from their perspective where they are with respect to the targets, and then begin to question, okay, is this even realistic? And if it's not realistic, are there ways we can try to accomplish this goal? So are there various intervention mixes that we could try? Could we advocate for more resources? But what this model helps us to do is really to see how far in terms of the intervention mixes, how far are they from the targets if we were to implement them, and how much can we achieve with them? So that is what I think the value is, but I don't know if it's the role of the model to tell policymakers that they are, this is an unattainable goal, because we really want to, eliminate malaria. And I think that is achievable and has been achieved in the US, because the southern part of the US used to have malaria. So why can't it be achieved is the question I think that we really need to ask. And the plans that we have, could we do better with respect to the plans, with respect to the coverages, with respect to investment? So that's kind of how I'll think about it.
Yeah, that makes sense. Okay, another question coming back from Cache again. To what extent are you constrained to do very similar things in districts that might benefit from different interventions? Are your decision makers more focused on equity of allocation and apparent fairness versus equity of outcome, meaning reduction in disease burden?
I'm trying to read the question. It's a long question.
So I guess the question is sort of, are there political pressures that might say that the decision makers might have to be focusing on equity of allocation, in trying to be fair to different districts, as opposed to equity of outcome, which might mean reduction in disease burden? So do you have to give something to location A, even if the overall benefit might be better if you gave it to location B?
So the goal here is to tailor interventions to reduction of burden. That is the focus. Equity is based off of what, the information we receive. While that it could potentially be something they are thinking about, is the goal with respect to our modeling, and what we are asked to do is really to identify how the interventions that he had brought together would, or they had decided upon, would bring about a reduction in burden. So the focus here is really, will these interventions bring about a reduction in burden and less equity? I think even with the idea of the high burden to high impact initiative that the WHO has in mind, that really underpins this work, is really about reduction in burden. I think equity, if you think about equity, really is it what's going down that route? Because I think that's also an argument that has been made with respect to the distribution of nets. Maybe we should distribute nets everywhere. But I think that there's a shift in thinking now, because if you were to give nets to everybody, you're probably going to end up with people that don't really need those nets. And so you want to give it to the people that need them, because malaria is heterogeneous and there are areas where there's almost little to no transmission. So that's, I think, where the thought is with respect to how interventions are given in the global space.
Mm-hmm. Right. It seems like this is exactly where, though, the question of political will and political externalities could come into play, depending on how people perceive these plans. And that's the trick, right? Is also the communication of what is going on and how that would affect everybody. Very good. Any other questions? Well, I'm gonna, if I may, just ask one more here. That, have you thought about displaying or communicating any of these results in terms of cost benefit or comparative cost effectiveness kind of displays? Because it seems if the cost is an issue, then that's one way that the decision might be supported.
Yeah, that is something I think we've thought about, and there's someone in our group actually working on cost effectiveness of interventions. But the numbers, like getting how much things cost, is very difficult and very challenging to know. With this, I don't think we have that information, for Nigeria as that now. So yeah, it's something I think that is in the pipeline, but I don't know if we have the data that is needed to do that very well.
Mm-hmm. Absolutely. I wouldn't want to imply that was simple or straightforward.
No.
Great. Well, thank you.
You.
Anybody else? Going once, going twice. So hearing no further questions, I want to thank Dr. Ozodiegwu for her time and this interesting talk about a challenging set of problems regarding malaria in Nigeria. And we really appreciate your taking the time with us. And thank you, everybody. We'll see you next month for the March webinar.
Thank you.